Hi everybody. In this presentation we will see an overview of the use of ultrasound for evaluation of COVID pneumonia. Thanks to Soldati that helped me in making this presentation, and thanks to the authors that gave me some videos and images. What we need to perform COVID pneumonia ultrasound is an ultrasound machine with convex probe. Also the linear probe is useful if available. We need an eventual probe cover to protect our probe, and a possible protection of the ultrasound machine with a replaceable film. Wheeled portable scanners are preferable in terms of easiness of protection and disinfection. Especially tablet-based ultrasound with touchscreen commands are easy to clean. We know that ultrasound is based on mechanical waves. Mechanical waves pass through tissues that are means of propagation. They are absorbed, reflected, and refracted. Every means of propagation is characterized by a density, impedance, that is the attitude by the tissue to conduct ultrasounds, and a propagation speed. The means of conduction have different physical characteristics. Some means of conduction, such as air or lung, have a minor density. Bone has a major density. Muscles, fat, water, blood has an average density. The more density means more speed of conduction and means more impedance of the tissue. So we must know that the limit between two different tissues with different density has a different representation in ultrasound. So we must know what is an interface. The interface, that is this limit, is more wide, more strong. The more the difference in density between the two tissues is high. So when we go from a low density tissue to a high density tissue, we will have a strong interface seen in white in ultrasound machine screen. The same is when we go from a high density tissue to a low density tissue. So when the difference between the density is not important, that the difference is from a higher to a lower or vice versa. The importance is the difference between the two tissues. We have a strong interfaces, such as between muscle and bone, or between muscle and lung. Two tissues with similar density have a lighter interface between them. Let's see the normal appearance of lungs by ultrasound. The examination should be performed on the entire thoracic surface in a sitting position and with the patient is lying down in a lateral decubitus. It is important to examine the posterior areas in particular, because in COVID pneumonia they are the areas that are more involved in the pneumonia. We have to perform longitudinal cranial caudal scans, transverse scan along intercostal spaces. The average running time of the exam is about 10 minutes, but it depends so much on the condition of the patient. The more the patient can change the decubitus spontaneously, the more the exam is easy and fast. It depends also on the skill of the operator. The normal thorax has multiple layers that are easily identified by ultrasound. But when we arrive at pleural line, that is the surface of the lung, then we have something unknown, because ultrasound cannot pass through the surface of a normal lung. That is because the ultrasound machine we usually use are concepted to study ultrasound with a speed of 1540 meters per second. That is the average speed of conduction of the soft tissues. Lung has a lower speed of conduction because it's lower density and lower impedance. So ultrasound machines are not concepted to study the lung. So what we see of the lung is a pleural line, that is a regular smooth line that slides, A lines that are reverberation, mirror artifacts of the superficial layers of the chest wall, and the mirror is the pleural line, and B lines that in normal conditions are light and do not dilate the A lines. So the pleural line is a hyperechoic single line under the surface of the ribs. It represents the interface between the tissues of the chest wall and the lung. It has a smooth profile, is regular, and slides during breathing. Lung artifacts are principally horizontal artifacts and vertical artifacts, and the lung tissues is replaced but not represented by the artifacts. They are not real structures, they are error of the ultrasound machine that reads the ultrasound signals that come back from the tissues. They are given by interaction between ultrasounds and lung interface. Only the surface, so is visible. The pleura acts as a mirror. An anatomical study of normality of the entire lung is not possible. Fortunately, as a disease involves the lung, we have a range of diseases that we can study with ultrasound. So pleural disease are easily studied by ultrasound, also diaphragm dysfunction, chest wall abnormalities. And about lung tissue disease, we can see all pathological condition that reaches the surface. What reaches the surface is explorable by ultrasound. So consolidations such as pneumonia, atelectasis, interstitial diseases from inflammatory origin, pneumonias, interstitial lung disease, ARDS, and then cardiac decompensation, acute pulmonary edema, and peripheral masses and nodules. So look at pneumonia aspects on ultrasound. The typical condition of pneumonia is an hepatization of the lobe with dynamic air bronchograms inside that are residual air into the airways in the involved parenchyma. This is the typical appearance of a bacterial lobar pneumonia, the consolidation. But usually the initial aspects of pneumonia is the interstitial, so-called interstitial syndrome. That is an increase in vertical artifacts that starts from an irregular pleural line. These aspects means an initial disventilation of the surface of the lung, of the peripheral air spaces. Interstitial syndrome has to be conceived as an intermediate disventilation situation of the lung between the normal lung and the consolidated lung. So we have in the beginning single B lines separate that, as the disventilation goes on, become a white lung with the confluence of these B lines. So look at pulmonary ultrasound such as a density measurement of the lung, a densitometry. Interstitial syndrome origins from the loss of air in the interstitial spaces. So as the peripheral air spaces lose air, ultrasound can pass the mirror of the peripheral air spaces, goes into multiple refraction that give multiple signals to the ultrasound that reads these signals as a B-line, a vertical line. These signs are aspecific, so they can be given by ground glass, by bacterial viral pneumonia, by interstitial lung disease, heart failure, ARDS, surface irregularities, or a disventilation. So we have to read this information into the clinical picture of the patients with laboratory symptoms and so on. Let's look at COVID-19 pneumonia. These are the typical CT scan pictures of the COVID-19 pneumonia. What we see in ultrasound are fundamentally three stages. Early stages with normal lung with fixed B lines in focal areas. Increased number of areas with focal homogeneous white lung associated with small subpleural triangular consolidations. Then there is an increase in consolidation in the posterior superficial inferior areas with following enlarging inside the parenchyma. Let's look at these features. These are the early stages. We can see a normal lung with focal areas of fixed vertical artifacts that can be separately be seen, and they present as a leopard spot, patchy in the lung field. Groups of vertical artifacts or wide vertical artifacts that start from surface irregularities, such them, and are fixed with a slide. Excuse me. Then we have an increase in number of the focuses with zone of white lung focal homogeneous with small subpleural triangular or hemispherical consolidation, and this is what we see. These are bands of white lung, and there are little consolidation on the surface. Then we have an increase in consolidation in the superficial and very posterior areas, which then widen inside the parenchyma. The transition to consolidation is generally a sign of clinical deterioration. We see this little consolidation, about 1-2 centimeters, that we see also in these videos. You see, they are such as hemispheric. There is a little hepatization peripheral of the lung with little bronchograms inside. Around there is white lung. As these consolidations go on and have a confluence between them, we have a worsening of the clinical picture. These features are described in this paper of the Chinese colleagues that describe the features we have already seen. Remember, as reported by our poster, lung ultrasound is more sensitive than chest X-ray in maybe all phenotypes. Ultrasound can be used in all clinical presentations of COVID-19 pneumonia with several purposes. Maybe in the beginning it could use to initially study the patients and detect early stages of pneumonia. In the severe pictures of the disease, it can use as a follow-up for evaluating the consolidation and take clinical decisions. The road we have to walk is very hard, but we have to walk it together. Thank you very much.